يلا. Okay. Bismillah ar-Rahman ar-Rahim. Okay, thanks for coming. So today we will discuss an interesting case that is honestly still I'm confused about, but yeah, and it's nice to discuss. Okay, okay. So these are our platforms, educational platforms. Okay, so this is a 13 years old girl who was previously healthy. However, with minor decreased appetite complaint 2 days prior to presentation, she was changing her clothing, then suddenly collapsed, like unprovoked. Um, the parents or the neighbor actually, who I think was a dentist or a doctor, started CPR roughly 10 minutes later. Um, and then EMS arrived around 30 to 40 minutes after, CPR was started. So there is definite delay. And back to the patient, she was otherwise asymptomatic, afebrile, no cardiac evaluation in the past, however. And when she arrived to the hospital, her echo was normal. Um, the With a negative tox screen in terms of family history, she does have a paternal auntie who died at 45 years of age while awake, unprovoked, but did have question mark seizures in the past. And then one paternal uncle, 42 years old, died while asleep, largely asymptomatic, just, maybe chest pain. Okay, this was the family is in Iran, the family history. Okay, so we don't have much details. Okay. Okay, so she had multiple ECGs, of course, after resuscitation. We don't have the ECG immediately or during resuscitation. She had multiple ECGs. ECGs are largely unremarkable, honestly. If she has QR pattern in V1, which could be a sign of RV, strain, hypertrophy, dilation, and she does have, ectopy. This looks like a supraventricular ectopy. You see this looks like a supraventricular ectopy here. She has another ectopy that is wider complex. So she has a little bit of ectopy, RV, H on ECG. PR is maybe a little generous, but otherwise normal ECG. Okay. Um, the She has a right axis deviation as well. Okay. And then another ECG, largely the same. QT was not was not abnormal. And another ECG. I picked up a couple of ECGs on her, but in general, unremarkable ECGs other than what we just mentioned, but the echo was normal. Okay. Questions about the ECGs, guys? Okay. I will I will proceed. Okay. If no questions. Okay. So um, in terms of sudden unexplained arrest or death, the majority of such patients indeed have cardiac disease, okay? Especially in less than 35 years of age, okay? And those with that are less than 35 years of age, predominantly the cause of cardiac arrest is inherited conditions, either electrical channel diseases or cardiac muscle diseases, channelopathies or cardiomyopathies. Okay. um, and there is a term that you might see once when you read about like a death sudden death syndromes. It's the term is SADS, or sudden arrhythmia death syndrome, which is defined as a sudden unexplained death in an individual with a negative autopsy and toxicology screening. Okay, just I want to mention that term in case you encounter it when you read when you in your readings. Okay, so obviously, like we said, the younger individual that dies suddenly, uh, the predominant causes are channelopathies or cardiomyopathies. These are the red colored or the orange colored, bars. And then as we get older, coronary artery disease gets more common, of course. Okay. So makes sense. Inherited diseases affect the young especially, and then ischemic heart disease affect the elderly. Okay. Um, and then, so when you encounter when you encounter a patient with sudden cardiac arrest or death, I mean, arrest, sorry. So you, first of all, you have, there are there is a large differential. You want to immediately rule out myocarditis, intoxication, electrolyte disturbances, and commotio cordis, which is like an hit into this chest, hit at the chest, center of the chest of a patient at a critical stage that induces VF. Okay. So you want to obtain that history, or you want to think of this condition if there is such a history. Okay. And then in terms of arrhythmic disorders, largely genetic etiologies. And like we said, cardiac muscle disease, HCM, DCM, arrhythmogenic cardiomyopathy, LV non-compaction, for example, channelopathy such as long QT syndrome, short QT syndrome, CPVT, and J-wave syndromes. As for example, Brugada syndrome, early repolarization syndrome, or cardiac conduction disorders like sinus, severe sinus node disease or AV node disease, or that, patient presents with bradyarrhythmias and perhaps cardiac arrest. Okay. Obviously, WPW might present with sudden cardiac arrest. So this is indeed one differential. And otherwise, structural heart diseases such as mitral valve prolapse, mitral annular disjunction, coronary artery anomalies, or history of coronary artery surgeries, for example, Al-Kappa or transposition. If you have an obstructive lesion, severe aortic valve stenosis, if you have ventricular scarring, for example, patient post-tetralogy repair, these are all patients that are at risk of sudden death. Okay. Um, and then obviously aortopathies, connective tissue disorders, bicuspid aortic valve are at risk of ruptures of large vessels and sudden death. And obviously significant dyslipidemia that might result with premature coronary artery disease. Um, and and then lastly, idiopathic, often because of PVCs that are that come in at the critical period where and at roughly at the end of the T waves, like early onset PVCs or short coupled PVCs that trigger VF occasionally. Okay. Obviously, non-cardiac causes do exist. For example, large pulmonary emboli, status epilepticus, and so forth. But cardiac disorders are really one of the main differential when someone presents with sudden arrest. Okay. Questions, guys?
No, no. It's
Okay.
fine.
Okay. So I hope you are familiar with most of these terms that we just mentioned. We mentioned many of them in the past, okay? Okay. So in terms of guidelines or recommendations, when you encounter a patient that survived from sudden cardiac arrest, um, obviously you wanna get a very, very good family history, personal history, any witnessed history, like people that were around during the arrest. You want to retrieve this patient medical records from the past if there's any prior investigations. You want to examine the patient fully. You want to do tox screening, electrolyte, testing. You want to obtain DNA sampling. You want to, do obviously ECGs, Holters. You want to, you can also do high precordial lead ECG to screen for, something called Brugada syndrome, which we will mention. Obviously, echocardiography. maybe we'll do cardiac MRI. If we're worried about coronaries, maybe we'll do a CT, coronary artery, and so forth. If the patient, if EMS arrived to the patient and they shocked the patient, for example, it would be nice if we can get the tracing from the EMS, and so forth. So there is extensive history taking and examination that you should do and investigations. Sometimes we do exercise testing. There is provocative testing. For example, we do something called sodium channel blocker challenge test, which I will discuss as well. Some people do other testing as well. And lastly, genetic testing is often required. Okay, so there are, and if you come to my clinic, we typically do all those or try to do obtain all these pieces of information so that we figure out the etiology of the cardiac arrest. Okay. So just really quick, when high lead positioning ECG is just we place an ECG you have to place ECG electrode in the second intercostal space and the third intercostal space and the fourth intercostal space across the sternum. Okay. So typically we start with the fourth intercostal space, but in this case we want to do second and third intercostal space in addition to the fourth intercostal space. Okay. Um, so, furthermore, ask if there's any recent viral illness, any medications, any muscle weaknesses, any history of epilepsy, any specific triggers, any hearing deficits, and so forth. Okay. And then metabolic screening, especially in younger individuals, is often recommended as well. Okay. So, very complicated testing and history to do. Okay. And then when you examine the patient, you want to, there are specific cardiac diseases that have, manifestations when you examine the patient. For example, issues with the hair and the skin and arrhythmogenic cardiomyopathies. You might have joint contractures, you might have muscle weakness and specific syndromes that result in cardiac arrest, and so forth. Okay, like digit issues with Anderson-Tawil or Timothy syndromes and so forth. So there are many things that you wanna look at when you examine the patients because they might provide specific hints. So, and obviously Marfan syndrome, like phenotype. Okay. Um, Okay. So, furthermore, if the patient indeed died, then in addition to all, like you want to obtain as much information as you can, but obviously, it's very important to get a DNA sample, and bank that DNA sample. This is very, very, very important. And it's very important to try to get any rhythm monitorings from the EMS or AED that was applied to the patient, if it was applied to the patient. We don't have autopsy here that we typically do, but obviously, if you have a cardiac pathologist, and autopsy is obviously very important, and so forth. Okay. So, one main thing that we need to, before the patient is buried, we want to get DNA sample if we have a suspicion of a genetic disease. Okay. And then thereafter, if there is indeed something pathogenic that came back from the genetic testing, then we have to screen the rest of the family members. And then we, according to the diagnosis, we do specific evaluation for the rest of the family members. Okay. And then, so if you remember, I always, if you paid attention, I always ask for parents' ECG, parents' echo, parents, medical records, siblings, so that I get to understand or try to figure out why did this individual passed away suddenly. And now that I don't have that individual in front of me, I have to, what I have left is the parents or the siblings, and we usually study them fully so that in order to try to understand the cause of the cardiac arrest for that individual and then protect the rest of the family members. Okay? Okay, so back to the patient. So, there is no obvious cause, of course, of her cardiac arrest. She did not die, she just arrested, but then she had severe brain injury and she's still in the hospital. She was apparently shocked in the ER, but there's no rhythm recording that is available to me. Okay, so I don't know what did they shock her for. Was it VT? Was it VF? Was it just white QRS because of severe acidosis? And then people thought it's VT. I don't know. So this is a very important piece of information that we usually lack in the ER. There's no good documentation. They often shock the patients without us like able to review the rhythm prior to the shock. Okay, but apparently they shocked her, so maybe she indeed had VTVF. I'm not sure. Okay, okay. So back to the patient. She's obviously now having severe brain injury. She's intubated. She's trached. She's bed bound. So we cannot do, for example, exercise stress tests. But we did echo, we did ECGs, we did rhythm monitoring. There is no subsequent arrhythmias that um, we were able to elicit, but we can do obviously high chest leads, like we said. And then this is her high chest leads. There's no specific. Usually we do this test to look for Brugada phenotype, and I will discuss it further. But there is no Brugada phenotype with high chest leads on her. She has QR pattern in V1 um, here, right? That is persistent. And she has a little bit of here, another ventricular ectopy here that is infrequent, apparently. Okay.
بكرة.
Huh. Oh, so we have Manal, Mirvet, Samir that came. Okay, thank you. Okay, you guys came. I don't know when did you guys came in, but I hope you're following. Any questions so far?
No, it's okay يا دكتور محمد.
Okay. Okay, so no clear obvious etiology so far, okay? No clear phenotype. Okay. Next is now I wanna try to examine the family. This is the father ECG. Again, unremarkable. He has the PR that is generous, otherwise unremarkable. Okay. And then father high chest leads, again unremarkable. Okay. Mother ECGs are normal, but I don't have them with me now, but they were normal. So we did echo for mom and dad, both are normal as well. Okay. And then she has, I think, two more siblings, both had normal ECGs and normal echoes. And we also did exercise stress tests for the rest of the family member, all were normal. Okay. I think dad has a one rare PVC or very few rare PVCs, otherwise normal. Okay. And the PR, remember dad had a little bit of first degree heart block that improved with exercising. So the phenotype is unclear. There is, like we said, evidence of RV hypertrophy or dilation on ECG, but not on echo. There is a little bit of ectopy that may or may not be specific. She was shocked for maybe VTVF. We did not do cardiac MRI on her because she's not in a good state, but otherwise, and we cannot do obviously exercise stress test on her. So we cannot really examine the patient fully. She doesn't have otherwise any syndromic features or any manifestations on her exam. And then electrolytes were normal and there's nothing obvious. Toxicology screen was negative, like we said. And like we said, dad has a little bit of first degree heart block. So, our differential is widely open, but obviously, she might have cardiac channel disease that is not obvious on exam. But there is obviously no cardiac muscle disease. Brugada is something that, I was worried about because There is family history of death while asleep, which happens with Brugada. There is V1 changes, though not classical. There is first-degree heart block in dad. That is also, that is associated with Brugada. So there is a little bit of Brugada, maybe, but definitely nothing diagnostic. Okay. So, so I want to talk about Brugada because many people asked about Brugada recently, and it's not that common. So let's just talk about Brugada really quick before we continue. So it's an inherited. Do you guys know Brugada syndrome, or you guys don't know much about it, by the way? Anyone?
هو صوديوم channelopathy.
Okay, so you know something about it. Yes.
صوديوم channelopathy
Okay.
causes
Okay, so it's an inherited arrhythmia syndrome. It is, not super duper rare, at least internationally. It's around 1 in 2,000 individuals, but more symptomatic in middle-aged Asian men. Okay. It is characterized by a specific phenotype, which is J point elevation of at least 0.2 millivolt with coved SC segment elevation, like, morphology, and T-wave inversion in at least one right precordial lead, that is V1 or V2, and positioned either in the second, third, or fourth intercostal spaces. Okay, so there's a specific morphology that you have to, see, with J point elevation of at least 0.2 and coved segment and T-wave inversion. Okay, and that morphology is very unique to Brugada. Okay, obviously such patients are at risk of VT and VF, but imaging is typically normal, and then they also are at risk of atrial arrhythmias as well. Okay. Just I want to pay, I want you to pay attention to, for example, here in lead 2, if you look at the ECG, obviously it looks normal. And then when you look at V1, V2, V3, obviously it doesn't look normal, but then you don't know where is the J point is. It's difficult to determine where the J point is. So you, you can, the end of the QRS and the beginning of the T wave is the J point. And it's obviously, you could easily determine that in lead 2, and then you can use this to figure out where's the J point in those V1, V2, V3 leads that are difficult to, to exactly pinpoint where's the J point. And this helps you knowing the J point is elevated to 0.2 millivolt or more. Okay. Because if you look at just view, if you don't know where's the J point, you might think J point is here, and then you might not call it J point elevation. Okay. Anyways, like what Dr. Sahar was saying, it's a sodium channelopathy, loss of function in SCNA5 gene, which is the main cardiac sodium channel. Okay. It is only seen in the roughly 20% of true Brugada patients. And that ECG that we just saw it could be transient. Okay. So one day the patient might manifest that ECG. Next day, the patient might not manifest that ECG. So it's a very tricky diagnosis. And in order to diagnose Brugada, you really have to look at that. You have to document that classical ECG. So it's very tricky. Okay. There are other genes that are quote unquote associated with Brugada, but their level of evidence is very low, and it's usually not considered pathogenic or likely pathogenic or disease-causing mutations. So only SCN5A gene is now is definitely associated with Brugada. The rest, there are other genes that are weakly associated, but it's not definitely considered disease-causing mutations as of yet. Okay. Obviously, there are false positives, meaning you might have a benign mutation or variation in SCN5A in such patients, and you might, thereafter falsely label a patient with Brugada especially if the patient doesn't have the Brugada phenotype. So you want to be careful. You don't want to label a patient with Brugada unless you see the classical ECG. And then genetic testing only confirms your initial diagnosis, but without that classical ECG, you cannot really call a patient a Brugada patient, okay? So, genetic testing is complicated. There are, benign variants, there are unknown significant variants, there are pathogenic, likely pathogenic variants. So you want to, not any variant in SCN5A is disease causing, okay? And then usually genetics for Brugada are more complicated. There is usually multiple genes or variations in multiple genes that are required such that the patient manifests Brugada syndrome. So, so it's not just usually one gene, it's multiple genes, but one of the main genes is SCN5A. Okay, but it's probably there are more than one gene or more variations or more mutations, multiple mutations or multiple variations, couple of genes in order that the patient should inherit before manifesting the disease. So it's a complex heritable pattern. Okay. Okay. So further complexity of sodium channel mutations. When you have loss of function of sodium channel, patients might manifest with like sinus node disease, heart block, Brugada, early repolarization syndrome. Um, so there are many phenotypes for one gene mutation. Okay, so the patient might have multiple phenotypes. Okay, and if you have gain of function mutations, you then might have long QT syndrome, atrial fibrillation, different phenotypes. Okay, so with variations SCN5A, the variations in SCN5A might result in loss of function or gain of function. And then when you have loss of function mutations, the patient might manifest with a couple of diseases. There is gain of function mutation, patient might present with a couple of diseases. So it's really complicated genetics. Okay. And then you wanna make sure that many people confuse typical Brugada phenotype on ECG with other stuff. For example, typically right bundle branch block. So, for example, that ECG on your this ECG is not Brugada ECG. It's an RSR, and the J point is here. Okay, so there's no J point elevation. But many people might confuse this morphology with Brugada, and then they might artificially call the patient Brugada syndrome patient, and so forth. So you wanna understand how the Brugada ECG look like, and how right bundle branch block look like, and all these other changes. All these other differential might result in RSR prime or changes in the ECG that resembles Brugada. Okay, so you want to pay attention. Okay. Is it clear to anyone that this is not Brugada pattern? To everyone that this is not Brugada pattern, right? You guys, is this clear to you, or it's not that?
Yes. Yeah.
Okay? Because I get phone calls from people, is this Brugada? Is this not? This is definitely not Brugada. Okay. Okay. So what is the sodium channel testing that we might do for such patients? There are a couple of agents that we can use, but flecainide is a sodium channel blocker drug. Okay, it is available in an IV form in Kuwait, so this is what we typically use. But elsewhere, people the most famous drug is agmaline. It's available in Europe, and then procainamide is available in the US. So there's flecainide, agmaline, and procainamide, but we only have flecainide in Kuwait. Agmaline is the most sensitive drug, but has higher false positives. And then it's a shorter half-life and more stronger sodium channel blocker, so this is why it's preferred. Okay. But because of the false positive rate, you want to really do it if you are really wondering about Brugada for any individual. Okay. So you want to you don't want to do it to anyone. You want to do it to people that you do have a high pretest probability. Okay. Obviously, during the test, you might induce VT, VF, heart block. So it's not a benign test to do. and such patients with existing conduction delays or SCNA mutation are more at risk for developing complications from the drugs. Okay? And when you do such testing, if you don't see Brugada pattern, then it is called negative. And if it's negative, then this is against Brugada syndrome, okay? In adults especially. So you can, if let's say you have a patient with Brugada syndrome, and if you want to screen the rest of the family members, like we said, the Brugada syndrome is transient. So you can do this provocative testing. And if they don't manifest, the Brugada pattern, then you call them negative. If they manifest Brugada pattern, then they are Brugada, potentially Brugada syndrome patients, okay? So, you can offer sodium channel blocker testing to all patients who their testing has been negative and they had cardiac arrest, or to people who had cardiac arrest that is suspicious for Brugada, and but there is no clear Brugada on their ECG yet. Okay. There is something called type 2 or type 3 Brugada, which just means that there is J point elevation, and but not, like the type 1. It's a saddle back SC segment elevation, um, like here, okay? It's a saddle back, it's a classical look for type 2. And then and then type 3, if the morphology looks like type 1 or type 2, but there is less than 2 millimeter elevation, okay? So if you have such type 2 or type 3, but not type 1, you can offer provocative testing. And if those ECGs turn to type 1, then that's more suggestive of a Brugada syndrome patient, okay? Again, this is an example of RSR prime in V1, not Brugada. This is an example of type 2 Brugada, which is non-diagnostic, okay? Here rather, okay? Like saddle back morphology, okay? And then remember here, like the T wave is upright, and with type 1, the T wave is negative, okay? Okay, so in general, when you suspect Brugada syndrome, you should consider sodium channel blocker testing, especially if there is cardiac arrest or syncope, family history of Brugada, family history of sudden unexplained death, or type 2 or 3 Brugada ECG pattern with other features, with other ECG features, okay? But if there is no suspicion of Brugada on history, or there's no cardiac arrest on history, maybe it's not worth it, okay? Because of the issue with the concerns of VF, VT, heart block during the testing, okay? The advantage of performing sodium channel blocker testing is, you can exclude Brugada syndrome. It clarifies the diagnosis and so forth. Disadvantages, like we said, there is complications from the testings and false positives rates and so forth, okay? So this is very technical, but this is just a guide of when should you do Brugada testing, sodium channel blocker testing or not. We do it once in a while, but we don't do it very frequent. But once in a while, we definitely do sodium channel blocker testing here in Kuwait. Okay, for pediatrics, if you have a pediatric, individual that we are testing, we usually do ECGs, high lead ECGs. This is a pediatric individual who has a first-degree relative with Brugada, and this individual is not yet diagnosed with Brugada, or there's no manifestation of Brugada on this individual. we do, standard high chest ECGs, at age 3 years. But if negative, we do additional screening until age 15 because, like we said, it could be transient, and the the disease is expressed more often at a higher age. Okay, it's not very common to see Brugada ECG at below 15 years of age. Okay. And then it's not recommended to do provocative testing for individuals less than 15 years of age, okay? Because there's a higher risk of adverse events. You need to sedate the patients if less than 15, probably, and then the sedation might alter the results of the test. And then if the test is negative under 15, when you repeat the test above 15, it might turn into positive. So, when you do it before 15, it might not be very helpful, okay? Okay. So now how do you diagnose Brugada? Like we said, you want to see a type 1 Brugada pattern on an ECG. Okay. In the past, that pattern it's diagnostic for Brugada, whether it's spontaneous or after sodium channel blocker testing. Okay. But because of the limitation of the sodium channel blocker testing, now just by having provoked type 1 ECG is not diagnostic for Brugada. Makes sense, guys? Or I have to repeat this sentence? It's very important. So you need spontaneous ECG to confirm to have a definite Brugada diagnosis. When you have a provoked type 1 Brugada, it's not anymore diagnostic for Brugada. You need other hints or other findings to call this patient Brugada. Okay, guys?
Okay.
Okay, شوية confusing ولا not that confusing?
So genetic testing is a best one or what?
Is what?
Genetic testing.
شفيك. What was your question?
The question is the genes. Now, if we do provoked ECG and it's not conclusive,
We always do
No,
genetic testing,
do
but
genetics.
always. But but in order to diagnose Brugada, it's a diagnosis not based on
for
genetics.
ECG.
It's based on ECG. Okay, so you have to have that type 1 ECG to call it Brugada patient. Okay. Then if you have, let's say you say, okay, this is definite Brugada, you do genetic testing for prognostic issue of, prognostication, plus to help screening the rest of the family members. عرفتي؟ But genetics only is not, doesn't help you with diagnosing Brugada, okay? It might confirm the diagnosis, might help you understand the diagnosis, might help with screening the rest of the family members, but you need an ECG to call a patient Brugada, okay?
Okay.
Okay. Then if you have an ECG that is provoked, meaning after sodium channel blocker testing, is still not diagnostic. Okay, you need other stuff to call it Brugada. So in 2016, okay, there's a scoring system that is used to diagnose patients with Brugada. Okay, I will have you read that diagnostic, or scoring system. But again, provoked type 1 pattern is non-diagnostic. You need other stuff. Okay. So you need clinical history stuff, family history stuff, and genetic history stuff, and so genetics and so forth. So you need a couple of, that ECG plus other stuff to call it Brugada. Okay. And then in 2018 or 2022, sorry, or 2018 and beyond, this is how you diagnose Brugada, is when you have spontaneous type 1, okay, and or if you have, for example, someone who had cardiac arrest, okay, and has type 1 Brugada ECG induced by sodium channel blocker. So arrest plus provocative testing, but not provocative testing alone, okay, and so forth, okay. So you need, if you want to induce type 1, you need other stuff to call it Brugada, okay. Anyways, and this is type 1 again. You have to really get familiar with this morphology, okay. Okay, So T wave inversion, J point elevation above 2, and so forth. Okay. Okay. So now back to the patient. Okay. So this is dad. So you remember dad ECG was normal, but now we gave dad flecainide test. What do you think of his ECG?
I think
J
it's
wave,
Brugada.
J
Not
point
Brugada,
elevation.
G1.
Yeah. So that ECG turned into Brugada after we gave him flecainide. Okay. Obviously, ideally we should give flecainide to the patient who had arrest, but dad refused because she's sick, in the ICU, trached, and then her being less than 16 years old, being intubated, sedated, and so forth, challenging her might not be, might not be very helpful. But, I don't know. We went back and forth, and I said maybe we should do it for dad. And I was a little bit surprised that dad, had Brugada pattern with flecainide challenge test. I'm not sure what. I mean, I was suspecting Brugada, but I wasn't really suspecting positive testing. But anyway, so this is dad, having Brugada pattern with on flecainide. Okay. Anyways, so it's a confusing family picture because we did also genetic testing, and the genetic testing came back that is very confusing. Why? Indeed, the patient had a CN5A mutation, which makes sense, or not makes sense, which is further hints towards Brugada. And that mutation is labeled as unknown significance, so meaning it's not benign, it's not pathogenic, it's in between. People don't know. Okay. Has been described in, remember we said SCN5A mutations could be gain of function, loss of function, could manifest with, Brugada, early repolarization, sodium, sinus node disease, AV node disease, early repolarization, so forth. So that mutation has been described in Brugada syndrome. Okay, this specific variation in the gene was described in pediatric patient with sudden death. So it looks like it's a lot more loss of function manifestation. Um, but but what was confusing to me, that dad test was negative, and the mom was homozygous. So you understand the complexity. Father who has Brugada, provoked Brugada ECG, came genetically was negative for SCN5A. The patient who has no type 1 Brugada ECG, genetic testing came back with SCN5A mutation. Mom who has largely normal ECGs has homozygous SCN5A mutation, but we did not do flecainide challenge test on mom, or just we did ECG, stress test, and Holter. Anyway, it's confusing. So dad has Brugada syndrome because he has ECG provoked, but he has, remember, family history. So if you go to the Shanghai, scoring system, dad has probably 2 points here. Okay. Although he doesn't have type 2 or type 3 Brugada, he just had, ECG that changed to Brugada pattern. He has family history. Someone died with unexplained less than 45. He has 2, so he can get 0.5 points. So dad maybe he can, 2.5. And then if you look here, 2 to 3 is a possible Brugada syndrome. So dad has a possible Brugada syndrome. So it's a little bit, confusing. So we still don't know exactly what is the, reason for this patient to die or to arrest, sorry. But, definitely Brugada pattern, nice Brugada pattern that we elicited on that. Okay. Anyways, so dad is a possible Brugada patient. His daughter, arrest could be related to Brugada, because remember we said it's a complex genetics. This SCN5A that is present in the daughter might have nothing to do with Brugada. Maybe she's among the 80% who are Brugada without, SCN5A, and then mom has SCN5A homozygous and she has no disease. So maybe this SCN5A is really not disease causing, it's benign, more towards benign, and it's just confusing factor. Maybe dad has a Brugada, and he has some other genes that are causing Brugada that we don't know that this individual inherited. Okay, understood, guys? Do you understand me? So it's really
تمام
confusing, huh? Samir?
Yes.
Okay.
تمام يا دكتور
Okay.
تمام
There's still a question mark, okay? Um, okay. So back to Brugada in general, most patients are asymptomatic, okay? The risk of developing symptoms is actually very low, like 0.5% per year. Um, um, the you know the but it's really important to try to figure out the individual risk, because the first manifestation of a specific person, of any person, might be sudden cardiac arrest or death. Okay, so um, when someone presents with cardiac arrest because of VF, the risk of recurrent VF is really high. Okay, but only a minority of patients present with VF for sudden cardiac arrest. So most individuals do have a silent disease, but some have might develop VF, and then thereafter they will have repeated VF. So the disease could be very malignant, could be very benign. It's really difficult to predict, and hence it's really difficult for the physician to protect the physicians. Very difficult for us to figure out this individual is high risk or low risk. Okay. So like the known risk factors are, like we said, cardiac arrest manifestation, VTVF. Obviously, this is a high risk individual. If you have a spontaneous type 1, it's considered a high risk individual. Okay. But remember, this type 1 might be tricky, might come and go, come and go. Okay. طبعا the more it's present, the higher the risk that patient is. If there is sinus node disease, AV block, in addition to Brugada syndrome, age is above 55 years of age is usually, if the patient is above 55, there's lower chances of, VF, but below 55, higher chance of VF. Males are maybe higher risk patients. If you have STN5A, maybe high risk patient. If you have family history, maybe higher risk patients. If you do EP study and then try to induce VT or VF, and if it's easily inducible, that's a high risk probably patient. There are ECG patterns that might indicate higher risk. For example, if the QRS is really fragmented, if there is Brugada pattern, even on other leads besides V1, V2, V3. Okay. Um, if there's early reposition pattern and so forth. Okay. If the QTC is elevated and so forth. So there are ECG changes that might indicate higher risk individuals. Okay. We have to move a little bit quicker. Okay, so again, we said gene positive individual SCN5A mutations are higher risk individuals. If you have syncope with spontaneous type 1 is a very high risk individual, and so forth. Okay. So if you have an indeed mutation SCN5A, this is how that is pathogenic or likely pathogenic. This is how you usually cascade screen the rest of the family members. Otherwise, if you have gene negative Brugada, you have to do ECGs, high chest ECGs, Holters, that you might place the Holter higher on the chest. You might tell the patient, if you develop a fever, do ECG, because fever is actually, promote or provoke Brugada pattern in such individuals. Okay. Or you want to do provocative testing. Okay. But mind you, if you do provocative testing and the individual turned out to be positive, it's usually that individual is lower risk usually, and then there is no much change in medical management. So then you might just make the patient worry that he's Brugada syndrome patient without really treatment that is available. So it's a little bit, you have to really discuss with the individual whether you want to do provocative testing or not, because often it will not change your management. Okay. Pediatric Brugada syndrome patients are usually very challenging. Usually they are diagnosed after an individual died or or had sudden cardiac arrest, and you do cascade screening and you identify Brugada members, or sorry, pediatric Brugada members. They are usually asymptomatic benign if they have no symptoms. But once in a while, a Brugada syndrome patient presents, and such patients are really difficult to manage. They have a high mortality rate. Okay. So pediatric patients are often asymptomatic, but if they have symptoms, they are really bad patients. Okay, much worse than adult patients. Okay, so this is ECGs. This is our patients. So we have this family. We have like sibling one here and sibling two. Both unfortunately died. With the bizarre ECGs. If you look at the ECGs, obviously when you look at the ECGs, it's not, classical Brugada pattern ECG, but there is definitely J point elevation. And ECG, sorry, Brugada is definitely in your differential. And we lost both patients, but genetics came back negative. But I truly think these individuals are gene negative Brugada probably, and we are actually sending their DNA to a research lab, Brugada research lab in Montreal, Canada, I think. Dr. Cecilia Gonzalez, and she is hopefully going to help us understand this family. Okay. This is my friend from Oman who recently had a patient with SCNA positive mutation. I don't have the exact mutation. And then with a very wide, bizarre ECG, it's probably also J point elevation at some point. The pediatric ECG might not look like the classical type 1 in adults. It might be more confusing. But also he lost this pediatric patient. So I don't know this question mark Brugada as well. So they are rare individuals, but when they present, we often lose them. Okay. But so in order to, so what, how to manage them now that we're talking about management, usually we try to avoid specific drugs. There's a website called brugadadrugs.org that you have to avoid. You want to avoid cocaine and alcohol intake and large meals, and then treat your fever aggressively. Okay, because fever is a provocative agent. Okay, or provokes Brugada disease. Okay, if the patient is symptomatic, often ICD is required. Okay, so there's no really good drugs. Okay. طبعا acutely if the patient is having lots of VT, isoproterenol or quinidine are good agents. Okay, these are both. This is IV, of course, and quinidine is there's an oral form of quinidine that we don't have in Kuwait. Anyways, but the usual ICD is required. Okay, if the patient is asymptomatic, it's really difficult to figure out which patient requires ICD, which patient requires just monitoring. Okay, it's really difficult. Some people do EP study. Some people look at all the risk factors that we mentioned, implant loop recorders for rhythm monitoring, and so forth. Okay, but it's really difficult. Okay, but if you have an ICD and the patient still having symptoms, quinidine is a very good agent. And some people do ablation in the right ventricular outflow tract area. And there's another drug called cilostazol, which I don't think we have as well, is also another agent. Okay, so there are drugs that we can use, but ICD is your main management if the patient is symptomatic. Okay, really quick with ICDs, often because they don't require pacing, we will probably do a subcutaneous ICD, which is under the skin, and the lead goes under the skin and above or just adjacent to the sternum. Okay, but there's a newer ICD called extravascular ICD. So it goes under the skin again, but the lead goes underneath the sternum. Okay, like underneath the sternum. Okay, this one goes up besides or above, besides or not underneath the sternum. This one goes underneath the sternum. Okay, So the advantage of this EV ICD is this device is usually smaller than the subcutaneous ICD, and that because it's underneath the sternum, you can still pace the patient, but only when the patient is like emergently because it's painful. Okay. But so there's no need for transvenous ICDs typically, unless they have sinus node disease, a heart block, in addition to their Brugada. Like we said, as you know, SNF5A or sodium channel mutations, they might have overlap phenotypes. Okay. Okay. So ICD, if you have symptoms, ICD is your only, therapy. Okay. And we said about about EP study. Quinidine, unfortunately, we don't have in Kuwait, but does not replace ICD. Only you do quinidine if the ICD is declined or there is recurrent shocks with an ICD. Okay. Isoprel for VT, acute VT, VF storm, and RVOT ablation as well as an option, like we said. Okay. So we do, BLS, we recommend BLS training for family members. There's no contraindication to sports. And there are other agents. We said silostazole. There's like Chinese agents that are shown to be helpful, but obviously we don't have them. I don't think, at least, that there are like that might be helpful with on tested, but on small, either under experimental models or like on a few individuals. Okay, so in conclusion, it's really challenging to diagnose Brugada. Okay. There is an autoantibody test that is experimental that might be around one day, but otherwise you need that type 1 ECG pattern. Genetics are complex and yield is low. We said provocative testing is complicated. It might be, it might induce arrhythmias. If it's positive, it's not diagnostic. And there's no good medical management. And then we talk about gene therapies all the time, but for Brugada, because SCN5A is a large gene, it's really difficult to administer gene therapy for SCN5A. Okay. So gene therapy is not going to be coming around available for Brugada in the near future. We also have here in Kuwait another family with, not, to me, this is like right bundle branch block morphology ECG, but there's multiple family members of sudden cardiac arrest with a right bundle branch block and SCN5A gene mutation. So sometimes it's tricky. They might manifest, even right bundle branch block, but obviously, like we know, right bundle branch block is not usually fatal, but this family had multiple, death, and there is SCN5A mutation, and they're all having right bundle branch block morphologies on their ECG. So it's another interesting, family that we have. Okay. Okay. So I think I will stop here. Any questions before I stop recording?